computer. So we're going recording now. Yep. And let's share screen. And then perfect. Okay, so week 4, guys. They've been quite enjoyable. I'm just going to, for the next, I'll speak to Aaron off air after this, but in regards to the going forward after this, and I've got a few things to think about, just depending on what how the guidelines change, but we'll worry about that when we need to. But yeah, so what we're going through now is we've been through bony landmarks. We've done the shoulder and the arm. Hip and thigh is as I see it the exact same, just slightly different. It's just a lower body version of it. It's not deep pelvis, so we're not going to be going deep into the pelvis itself. Well, we actually will do from the posterior muscles, but not pelvic floor, not anterior compartment for today. It's really what I want to emphasize is the similarities between upper and lower body from a kind of biomechanical perspective and what they're trying to achieve. So recap of last week, just some stuff that should be known by now. I'm not going to go through all the different Latin terminologies, but we may come to that in a few weeks. But we've got 3-to-1 ratio of external rotators to internal rotators in the shoulder girdle. So that rotator cuff got 3-to-1 external to internal. We can go down the rabbit hole of how they change and externals become internals, but that would really require more of a, looking at skeleton where we can move things. I can tell you that they do change the roles both in the hip and the shoulder. However, seeing it makes a lot more sense. But we've got the external rotators, internal rotators that manage the shoulder joint. We have 4 flexors and 4 extensors that manage the elbow joint from a superior perspective, so from the upper arms perspective. And then we have 3 joint managers that link the humerus, the ribcage, the scapula, coracobrachialis, pec minor. And then on the posterior side, we have the teres major. So just some stuff to recap through that. And the reason why I want to recap with that is because it's very, very interesting why the principles behind those and how they repeat themselves in the lower body. So again, it's just a mirror image. So how do we remember the rotator cuff muscles and the origin of the deltoid? Now, I wonder how I can minimize this. Will that work? Nope. I just told you. Just want to minimize the side because it does record the screen, so I can't see everything. But so how do we remember that? So can you remember the acronym for the rotator cuff specifically? I wonder if I can. Okay. So so I'm asking you guys at home, just have a think about it. If you can remember the acronym. Let's see if I can minimize this because it records it and puts it up on YouTube. So where's my cursor gone? There's mute. Don't want to mute myself. Nope, not doing it, not playing ball. Try that. Show grid, that's a little bit better. Okay, so how do we remember it, guys? Have a little think about it. Let's try. Don't want to mute Aaron, move across. Ooh, I've lost it. So we've got the rotator cuff is sits. So supra, infra, spinatus, teres minor, and the subscapularis, and we go in through the greater lower tubercle of the humerus, and that's how we're going to be remembering everything in the rotator cuff. Why is that important? Well, because we've got to think about that principle of joint managers and how we're managing from a stability perspective, go into external rotation, then how we produce force going into internal rotation. But these are principles that we want to adhere to. So just to remember, let's try that. There. And the deltoid, we're going for 3rd class, and 3rd class is the clavicle, so the 3rd lateral of the clavicle. We've got the middle part of the acromion and the spine of the scapula. It's going into the deltoid tuberosity, which is pretty simple to remember because it's the name of the muscle, just the tuberosity where it goes. But 3rd class is the origin of that. So why are we thinking about this important at this point? Because I would say that the deltoid and the pec, so the pec major and the deltoid muscle, are essentially similar to the whole gluteal muscle groups. So any input so far, Aaron?
No, good. That's all good for me.
All good. Okay, so muscles of the hip and thigh. So first time meeting a couple of new terminologies. These are the longus and the brevis, which just means long and short. Brevis, if you want to make a kind of understanding of it. Brevis, abbreviate. Brevis just meaning Latin for short or smaller. Longus is pretty straightforward. It's already there in the word. So we've got longus and brevis. These are a couple of new terminologies which are going to be bespoke to the adductor. Vastus is bespoke to the quadriceps. Now people are pretty good. That's pretty mainstream terminology. Vastus, quadriceps, intermedius, medialis and lateralis. So vastus is bespoke to the quadriceps themselves. It means large or forceful from whatever you can Google in Latin, but that's generally remembering there. Adductors is the say what you see name. It's just adductors, then followed by the branch of the adductors, which is, and hamstrings, which are essentially your lower body biceps, which we'll look into in further on. But hamstrings, you got to think of their role is knee flexion and then managing and stabilizing the pelvis, helping extend the pelvis, extend the hip. Sorry. So hamstrings are your lower body biceps. So we've got biceps and triceps. We've got quadriceps and hamstrings essentially doing the same thing. However, the requirement for stability and the role in stabilization is a little bit greater in the lower body because it's a more stable structure. But as you can see, there's a tie over. Now, what we don't have, or what we do have, but maybe in a different manner, is upper body adductors. But upper body adductors, essentially, I would say is kind of the lats in a way. But we can go to town on how those work, but you've got to think about muscles that can work as internal, external rotators, but play a part in different functions. If you think about the lats can extend the shoulder in a row, or extend the humerus in a row, we do have portions of the adductors which can act as hip extensors as well. And we can have, as the lat can act as an internal rotator, so can portions of the adductors. So last week we had this diagram. We had 4 extensors and 4 flexors, and they acted on the elbow. This week they act on the knee. But what you can see here is out these 4 extensors, whereas when it was in the triceps, it was the triceps brachii and then the three heads of that. And then we had the anconeus. The 4 extensors is the vastus group, which can be a lateralis, an intermedius and a medialis. And then we have a rectus femoris. Rectus femoris is bespoke, or is unique because it crosses 2 joints. So it's, is it biaxial? Is that the correct?
Yeah, biaxial. Yeah.
That's the fancy way of saying it, biaxial muscle. So we've got to pay attention to that. It's going into the AIIS, so the inferior iliac spine, which is important to consider from a hip mechanics perspective, and especially from a knee mechanics perspective. So if somebody has knee pain and they have a change in pelvic position, that can sometimes come down to the rec fem itself. And how it's maybe hypertonicity, because that's going to be pulling on the patella tendon. So the reason why I want to teach it like this is just my version of teaching it, is because now we can see a blueprint of how the body works, and we're looking at the extensors and flexors. And if we can remember, there's 4 in the lower body, 4 in the upper body, and then they branch out into ones that are bespoke to one muscle group, and then one that slightly stands out. Now, the actual structure of them, so the way they look, is a little bit different. The rectus femoris and the anconeus don't really resemble each other at all, but the principle is still there. And remember, this is just a method of retention, so remembering. So if you can always remember, I need to remember the 4 flexors of the elbow, 4 flexors of the knee, 4 flexors of the 4 extensors of the knee and elbow as well. That's pretty much got you covered for the upper portion, at least, of both upper and lower extremity. The flexors. So flexors that act on the knee. Now we could argue, we could go into the gastroc, but again, that's going to be in the lower body, the lower extremity. But we've got the semimembranosus and the semitendinosus, and there is a reason why I've made the M and the T more pronounced there and in a different color, and that's because the membranosus, I just remember it as M for medial. So this is where we're looking at biomechanical planes and biochemical terminology. But the membranosus is medial, and that just helps me remember that's the innermost of the hamstrings, because it's closest to the medial line of the body. The biceps femoris has a long head and a short head. And as I said before, biceps femoris and your biceps brachii, they have 2 heads. So it's just one way of remembering that, and that acts as the 4 flexors of the knee. In terms of the actual structure and what they do, biceps femoris is a little bit more lateral, but it is lateral, which means that it has some external rotation capabilities in a flexed hip position in terms of joint management. the hamstrings, and this is where Aaron can come in. I think that even though we have no idea, well, we have a good idea, but we don't know exactly what we're touching as therapists. The tendinosis, in my opinion, is more structurally for structural integrity. And what I mean by that is that it has, and this is where me and Aaron can discuss, it's a little bit more, in terms of its purpose, there's part of the hamstring which is just there to kind of hold everything in place rather than act as a prime mover. I don't know what your thoughts are on that, Aaron.
Yeah, I've heard that theory.
And the reason why I presume that there's difference in the names and it's not a semi-intermedius or something is because it's the clue is in the name, tendinosis, so it's more of an attachment. And if you look at the slings of the body, the posterior slings and the deep back line of the body, the tendinosis is a very prominent point or muscle that lies on that line. And I do think that and the adductor longus are more for structural integrity. They're there to hold us together rather than be prime movers. Because I do think the systems that are layered upon systems, and what that means is that we have things that are just to structurally keep us in place and things that are there to help us move. So same principle. That's what I think the beauty of anatomy is and these things repeat. And if you can remember the principles plus the what goes in front, the Latin translations, it just becomes easier. But membranosus is medial, or membranosus to me, so it's closer to me, close to the center line of the body. With the biceps femoris, you've got a long head and a short head. Biceps femoris, I think, is quite a cool muscle, and it's something that's good to know the mechanics of when it comes to gait and walking patterns, because the long head goes into the ischial tuberosity and then the Sacrotuberous Ligament, and helps connect to so as a byproduct is going to connect to the sacrum. So its management in gait mechanics and how it acts on the sacrum is pretty cool. Especially with people with SI joint issues and further up the chain. But it's just really, really cool to see how muscles interconnect with different systems. And it was, for me, the biceps femoris is quite a key one in understanding that the gait mechanics. All right, so a model explanation. So how do I stop? So okay, no, so we're good. Let's stop the share so I can come back up. Let's get to speaker view. And then Aaron, so everybody should be seeing. Who can you see, me or Aaron?
I can see you, Chris.
You can see me, yeah. So
yeah, thank God.
That's good. Right, model explanations. So what I've got is I get to talk about the pelvis again, which I'm really happy about, because we're just going to talk about we've talked about muscles of the thigh. We're now just going to be talking about muscles of the hip, so everybody can see the pelvis model and everything that's going on here. We know now that we've got the femur, and the main things that you've got to remember. Now, we're not going to go into any quiz type of thing here, but what we should be able to remember is we have a body. Remember, it's just a little person. We have a neck, we have a head, we have a greater trochanter and lesser trochanter, and then we have some epicondyles round here and linear aspera round here, like so. So this is key, because if we're thinking about the attachments, so we're going to recap on the attachments. The vastus group are going to be, it's really quite simple. Lateralis is going to be origin round here, a bit more laterally. So this is medial because this is going into the hip. And then we have body of the shaft, the upper anterior portion of the femur, which is going to be for the rec fem. That's probably going to be attaching, where would you say, all the way down, or is it, where would you say, Aaron, right the way through? Or
it pretty much, it covers the entire front periosteum, the entire sort of anterior sort of portion of the femur. Yeah,
it's quite a structurally integral one. And then they've got the medial vastus medialis, which is coming round the medial side. So it's quite a simple attachment if you think about it. But if we know the bony aspects, which we've been through the femur, then we're going to be pretty sweet with the origins of the vastus group. The rectus femoris. If we look at our pelvis here, we've got the anterior superior iliac spine, then we've got the anterior inferior, which is kind of a nodule, which isn't palpable. It shouldn't be palpable on many people, anybody, but it's just a bit lower than the bony bit of your hip. And this is going to be the origin of the rectus femoris. And as a collective, all four of those muscles, are going to go through and into the over the patellar tendon. And depending which way, it would depend on what anatomy book you get, because some of them will slightly differ. Some texts do. Is it going to be the tibial tuberosity or the patella tendon, one or the other? You can just learn both, as it's the safest way. But it's pretty much not the same thing. But patella tendon, tibial tuberosity are around the same region. It should really get a lower limb. It's not. It doesn't attach to here. It's a little bit lower onto the tibia, but that's where they go. So pretty simple in terms of an extension movement. In terms of different planes and what the capabilities, you could argue that the medius is a slight internal rotator, the lateralis is a slight external rotator. That depends on a lot of different things. Aaron, I don't know if you noticed, if you ever had powerlifters or people who squat with very wide stances who have vast amounts of tension in the lateralis, or maybe a little bit more muscle.
Yeah. So I think there's a fine balancing act between the quads from the outside and the inside.
Mm-hmm.
Vastus Medialis is the only medial stabilizer of the patella. So when you've got guys who are well developed and engaging in sports where you're using more the lateral side of the quads, you tend to find the alignment of the patella, because the femur starts to internally rotate, the alignment of the patella becomes more lateral, and then you start getting that horrible lateral knee pain or lateral hip pain. I think patella maltracking is a misnomer, which is the concept we're talking about. But I think via that process where the lateral quads are stronger than the medial quads, it starts to cause changes in the rotation, as you were talking about, the rotation of the femur, and that's what displaces the patella.
Mm-hmm. Yeah, no, perfect. So what I'll do is quickly just the hamstrings, and then we'll talk about knee pain. So guys, if you've got clients or yourselves who are struggling with knee pain, think about your questions now. And the thing is that things could come into light a little bit more. Now, really, didn't think this one through because I should have had a lower limb. But in terms of attachment sites, the biceps femoris is going to be on the posterior lateral epicondyle of the fibula, and then we're going into the tibia, the lateral epicondyle of the tibia for the semitendinosus and membranosus. Here is where my memory has failed me for I think the tendinosis goes into the PCL.
So semitendinosus goes onto the pes anterine,
mm-hmm.
and semimembranosus goes onto the tibial plateau.
Okay.
Actually, just at the top.
And does one of them act on the posterior cruciate ligament?
Posterior cruciate. I think membranosus gives a slip on posterior cruciate. But the problem is it's intracapsular, isn't it? The PCL.
Mm-hmm.
So you'd have to go through it would have to go through the joint capsule.
Right. Okay.
If that
I'm trying to think, because when we did the knee, we were talking about the one of the hamstrings which acted on the PCL, which can have an impact on it. But anyway, going through bicep femoris, lower posterior shaft, so around here. That is going to be a strong flexor of the knee. I think that really is, in terms of roles, that short head of the biceps femoris is going to be more the knee flexor, and then it comes through. They're going through and up, and the hamstrings are going to go into if we're looking at the pelvis here, everybody should know, be familiar with. This is the posterior view. We've got the ischium here, and we've got the ischial tuberosity, which is the kind of posterior tuberosity aspect of the ischium. Now, with this as well, now you can't see. It would be good if we could show, but then we're thinking about the Sacrotuberous Ligament, which is going from the tuberosity of the ischium to the sacrum here. As the name says, it's a ligament, so it's basically where my finger is there. I don't know if anyone can see. It's a connection there, and that is the bicep femoris is acting on that. Would love to go into that, but again, it's for a whole different day or a whole different topic. But it's basically because it's like an X. If you think about this lower X that's going through, which is managing the counteraction swinging of the sacrum whilst you're walking. So if you think about if your leg's going out to the side in slight external rotation, very, very slight, it's going to provide a slight stretch for the hamstrings. And because that's now increased the length tension in the bicep femoris, it's slightly bringing the sacrum to that side. So there's going to be a rotation in the the opposing side. So if we think about the sacrum in it can move it can rotate like that. So just think of it like you've got a tail which swings back and forth. Sacrotuberous ligament is very important for structural integrity in the pelvis whilst we walk itself. And if you happen to tear or sprain any of those ligaments, that's when SI joint and sciatic pain and a whole host of other things can come into play. Do you need to know that in gym floor? Probably not, but does it give you an idea about how everything is interconnected and why certain positions might exacerbate certain injuries? Yes, it does. So, anything to add, Aaron?
No, I was just responding to Tasha, who was asking a question about, is that why track runners have one-sided knee pain? Because of running the bends in the same direction, and that change in femoral rotation. No, you covered everything I think I would have done.
Sweet. Okay, right, guys. Let's do a quick Q&A. So, questions on, let's say, the knee. What has everybody got? Any knee pain whilst you've been, whilst you've been at home, or any knee pain with clients, any online clients saying they've got any issues, or is everyone A-okay? Okay. Pain during squats. Okay, Tash, do you want to elaborate, or do you want to just go? You're going to unmute yourself? Go and brave it.
Pain when squatting, when it feels like it kind of needs to kind of click. It doesn't necessarily hurt like after it's clicked, but lunges especially like cause a pain on the medial side of my knee.
Okay. Cool. So is it only brought on by training?
Yeah.
Okay. And is it what extreme? Is it the lower part of the exercise, or is it just unlocking or mid range?
Generally, kind of like the lower aspect of a lunge or a squat.
Okay. Cool. I want to let you go, and then I'll go.
Right. So I think, Tash, I would be looking at, first of all, foot placement. So you tend to find, depending on what your feet are doing whilst you're doing your lunge or your squat, that will play a big part in what your knee does higher up. So if you are a 10 to 2 squatter or a 10 to 2 lunger, your foot naturally drops into pronation. It's almost like the medial arch collapses in that position, which then focuses more force onto the inside of the knee. So as a result, you then tend to find you can start to get medial collateral ligaments, irritation, and some of the other structures around the inside of the knee. So the first thing I'd address will be foot position, play around with that and see if that changes things. And then after that, I'd be looking at the influence of the hips. So when you're in the bottom of your squat, do you drop into a valgus position? And if so, build some strength into the abductors and some of the hip musculature to make sure that you're externally rotated as you're in the bottom of that hole.
Thank you.
You're welcome.
Nice. I'd say this foot placement is massive with it. Just it's. I know don't want to sound like it's too simple, but it's just check your internal external rotations in the hip, and then check the ability to control. I'd say probably pronation, control pronation of the foot, because if you think about if you can't, you say big toe strength, but I think the kind of coordination of pronation of the foot itself is really important, because if that knee goes in, so it like falls in, we might get a kind of a strain or an irritation in the medial side, because it'll be the one that's opening up. So yeah, looking at the strength of the feet, but then do you have access to full internal rotation? If it was medial, I would guess is internal rotation. I mean, it could be either, but it's just that's where it becomes person specific. So looking at those, then the appropriate stability exercises to get those moving a bit better. But yeah, so anything to add on to that, Tash? Are you good? You can type it in the chat. Ooh.
I think the other thing with knees, which I tend to see a lot of in clinic, is I think there's this perception that you have to drop way below parallel, like quadriceps. Now, when you're, much below parallel, you tend to find that your knee joints and all the tendons and ligaments around the knee joint are maximally stretched, but also maximally loaded. So I see a lot of people who develop patellar tendonitis as a result, a lot of people that start to struggle with medial collateral ligament because they actually haven't got the range of movement to drop but much below parallel, even though they're forcing themselves with weight. So there's this valgus collapse that gives them that additional range of movement to get those hips below parallel. So I think squat depth is another really important concept when we're talking about knee pain.
I mean, if this is where this we probably go into a knee pain podcast, but then like with the squat depth, it's like squat depth is so bespoke. Like it's so person dependent, but not just like on lever lengths and how you're built, but also that person's current capabilities. Somebody could come in and just have one of those physiques or one of those structures where they can sit ass the grass, but that still doesn't mean they should be squatting with load to that if they don't have stability capability. So Tash just added onto that hypermobility. If you've got hypermobility of the knee, you've got, again, just slow it down, slow the tempo. But one thing that I spoke to with Nick quite a bit, where we say that stay within your range and just, I think from a nervous system perspective, stay within that range just before you expect to get pain and just play around with it, so your body builds confidence there. With a lot of rehabilitation, you don't want to shy away from it, but you might want to use load where you're building strength to a certain range and then go out of that and then go through the full range with load which doesn't exacerbate it, because essentially one of the biggest stresses is going to be when we try to add too much load too quick or lose stability and have to compensate to get ourselves out of it. So just go on to, so that's a really good one from Tarek about I get this is one of the most common questions that I get asked, and you'll be the same. Knees pumping. So
or shoulders, or any other joint for that matter.
So what's the deal with that? Is that something you've been worried about as an osteo, or is that what would you say is going on there?
No, I wouldn't be worried about it if it wasn't painful.
Mm-hmm.
I think it suggests there is a degree of the joint's not happy. So you're probably finding that you're starting to create some additional wear and tear on parts of the joint that aren't necessarily designed to be loaded. So from a synovial joint perspective, cartilage isn't the same thickness across the whole of the bone ends. Point on the cartilage where you maximally load the bone is the point of maximum sort of, body weight contact, if you like. So what you'll find is usually if the joint's out of position, you've got tight muscles pulling the joint forwards or backwards, and you're starting to load that part of the cartilage that isn't as thick as the other parts where it should be loaded, I think you start to get some degeneration taking place, and usually that's what causes the clicks. But if it's not painful, it's not something I would necessarily worry about. However, I still think it would probably be worth addressing joint mechanics, making sure that you've got full range of movement and everything around the joint is working effectively. I don't know what your thoughts are on that, Chris.
100%. Yeah. So with joint popping, it's the exact same. If it's not painful, that I'm not too fussed about it. Usually freaks people out, and some people are squeamish and they go, "Oh, that goes right through me." If I ever squat down fully to pick something up off of the floor and I bend my knees, both my knees will pop. But the thing that I'm saying is exactly what Aaron said. You got to think about what's attaches to the knee, what might be, so-called tight. What might it be worth stretching in because of that? The hardest one is that biomechanically some muscles aren't necessarily, bodybuilding will train everything, but if bodybuilding wasn't a thing and never been created, there's some muscles which wouldn't be directly loaded because they're not, I don't want to say not designed, because we're designed to do anything from a action perspective. So if we think about anatomy, about something going from shortened to lengthened, you're designed to take something from short to lengthened in anatomically, but in terms of the function of it, of how it integrates into a system, there's certain muscles that never really will be moved in a certain way. So, for example, a pike. Everybody was doing those like Rectus Femoris raises, which are fantastic for the hip and they'll help your knee, but that's not something which is a primal movement per se. And I'm not into primal training and all that, but one thing I love about your, not theories, Aaron, but the way you teach things is that you look at things through evolution, because that makes the most sense of how we're designed.
Yeah, absolutely.
And a pike or an isolated pike position is not something we'd ever do as a caveman. So what I'm saying so what I'm saying in that perspective is, and that's why that is an effective exercise, is that that's the difference between function versus action. Things click because they've never actually, you've done a functional movement, such as a squat or a lunge, but you've never actually trained the action of something, such as taking the rec fem through its full extension, which would be a full pike, like think ballerina or gymnast getting the foot to the head and then going back. That's not something I'd recommend, so please don't do that if you've got knee pain, but replicating something along those lines would help. So if you've got clicking of the knees and you do a few of those pikes, because you're stimulating the rec fem from a neural perspective and very local, and you might notice it goes away. That's, if anybody ever sees the stuff that I put up online, that's actually the one where I have somebody on the reformer and then lying back. I don't know what they're called. There's a name for them. It's like Matrix, Neo, like bending back things. Do you know? Have they got a name?
No. Yeah, I'm not sure.
You hold on to a band and then you just take yourself back whilst you're on your knees. But it's very
like a reverse Nordic.
Yeah, that's the one. That's the one.
Yeah.
But anyway, inflammation accumulates around the head of the fibula into pain after long amounts of time on my feet, but usually very sporadic, not really any pain when warm and training legs. Right? Okay, cool. I'll take this one day quick. Fibular pain. You got to think about the way the fibula head and the tibia are able to rotate around each other. And even though we think of the knee as a hinge joint, which obviously is, there needs to be a slight level of rotation and translation between the tibia and the fibula around there. And you can lose that. Maybe some tightness or some over pronation, over supination. I'd go with pronation on that foot might then restrict that, and because it's not flowing right, when you're stood on your foot, you might be favoring one side for whatever reason. A foot's in a static position, and because they're not moving right, there's an accumulation of maybe lactic acid or whatever metabolites around that region. So I would say it probably isn't a exercise thing you need to do. It's you look to release the head of the fibula. If you went into where the pain is and went a little bit lower down, and then just had to play around there, you'd probably find some bits which probably feel like they need a bit of work. But over to you, mate. What would you say, Aaron?
I would completely agree with what you've said, and that's a common problem that we see with reduced range of movement in ankle dorsiflexion. So again, we look at the fibula. Reduced knee flexion, again, we look at the fibula because it's a contributing factor. I would also probably look at some of the structures that attach around there, because you'll often find a restricted joint generally wouldn't cause inflammation. An irritation to your biceps femoris, your IT band, or your lateral collateral ligaments, one of your musculoskeletal tissues, has probably got a higher probability of causing, if you can see visible swelling, it's probably going to be coming from one of those structures. But yeah, a combination of working through the fibula head and trying to identify whether it's biceps fem, lateral collateral ligaments, or IT band. It's a big junction area for quite a few different structures in that region. And I'll be looking at those as well. But yeah, completely agree.
Sweet. We'll take one more on the knee, just a quick one for Henrik. We'll cover what your question in the, we'll cover it in the hip because it's a little bit, sorry, in the hip, when we talk about the hip and the adductors. It's a specific one strength. Feet, Martin, just a quick one with the feet. Aaron and I did a podcast pretty much specifically all about the feet, so I'd recommend giving that one a listen just because you'll have a full hour to go through. We talked about that quite a lot in terms of strengthening the feet. So just let's go for one which is a little bit more barefoot training. Again, the same. The podcast that Aaron and I did. Okay, a client of mine suffers from pain across the top of the knee, which worsens when squats. This tends to ease when they roll it out on the foam roller, but keeps coming back. Any suggestions what this is causing? Okay.
Yes. Do you want to take this, Chris, or do you want me to do this one?
You can go first, and then I'll chip in.
Okay, so Hattie, I think, hi Hattie. I would hazard a guess, and again, it's obviously depends what you mean by the top of the knee. I would be putting my money onto a quadriceps tendonitis. So as the quadriceps diverge or converge into one tendon, you often find on the suprapatellar, so the top of the patella, you start to get irritation through the tendinous structure there. So it's a bit like patellar tendonitis, but it's higher. It's a quadriceps version. And the reason it goes away is obviously because you're loosening the quads off when you are rolling them. I'd imagine it's the quads that you're rolling. And it comes back because tendons, unlike muscle, when they start to get painful, they start to degenerate. And what you have to do with tendons is reload them back up. So some isometric exercise, some heavy eccentrics. So that it's almost contrary to what your client and what you think will be doing. You'll be thinking, right, we need to rest it. We need to take the pressure off. And I would say you need to do the opposite. You need to have a graded reloading program, starting with some isometrics because they'll give you the tendons some load without producing too much discomfort. They also offer a bit of analgesia, so some pain relief. And then I'd be moving into heavy eccentric training. And that's why it doesn't go, because you've not gone down that route, I would imagine. I'm assuming that, Hattie. You can nod or shake your head if that's... Just laughing there.
So agree with that, Aaron. I'm hold my hands up in regards to the non-muscular structures, tendons, ligaments. Aaron's knowledge would be much better than mine in regards to protocols. That's not something that I've been doing as a personal trainer for that long. But what I would say from a structural perspective, one thing that just getting your head around things, I'd like. I do definitely recommend what Aaron is saying, but also maybe opening up the hip during a leg extension movement, so leaning back. And the reason why we're doing that is we're gonna teach that rec fem how to stretch a little bit, and so contract through a greater range of motion. So you wouldn't want to go as aggressive as lying, and there's not many things that you can do. If you've got one of those lying leg extension combos at your gym, doesn't matter now at the moment anyway, but if you can do something where they're doing a leg extension in a hip extended position, I'd go down that route as well as a movement. If you think about it as well, you could get them to do a standing leg extension with a band, which is going to be actually, if you think about the mechanics of it from a strength curve perspective, it's actually pretty good, because even though the band's getting stronger as we're extending, it's still going to be pretty safe because the tendon's going to be shortening. So I'd say that'd be, anyway, the band, as long as it's not too aggressive with the band. And the reason why I'd like that is that you're just teaching that rec fem how to contract and extend the knee just in a longer position. So maybe if they did like a quad stretch, that famous quad stretch you see everybody do after, before and after training, do that, but they have a band around their foot and they're holding that band and they're taking themselves into a leg extension. That might just stimulate that rec fem to release in that sense, maybe as a warm up. Give it a try, see where it goes.
So Hattie, if you're interested, on our YouTube channel, which I think is Mofo Body Mechanic, I did a webinar on tendon problems, tendinopathies, tendonitis, tendinosis last week, and I think we've recorded the webinar and that's now on YouTube. So if you're interested in learning a little bit more about the rehab side of things from a tendon perspective, it goes through right from what tendinopathies are all the way through to rehabbing your tendinopathy. That might give you some ideas and some help.
Sweet, perfect. If you want to, I don't know how, I think you can unclick off it. If I share screen now and crack on, if you can find the link and pop it in the chat, Aaron.
Yeah, cool.
Well. Yeah. I'm going to crack on with the rest of it. Screen share again. So there we go. And guys, at any point, because I've tried to change it, if you don't want to be, I'll just move that out of the way. See if we can get that there. There we go. Right, model explanation done that. Right, please give £1. So that's what I've come up with. So please give £1. I know you're thinking, what the hell is he on about? Please give £1. If you can remember that, the hip external rotators. Some of you may look at a picture of the glute or the deep hip muscles and go, what the hell? And they can be really scary and they can be very, very difficult. But if you remember the acronym, please give £1. The rotator cuff of the hip, which obviously is not the rotator cuff, but same principles. Now, I know I said there's 3 to 1, but if you think about the range and the stability required in the hip itself, we have extra muscles which help just because of the complexity of the structure. But please give £1. What does that mean? Piriformis, gemellus, obturatus, quadratus femoris. So please give £1. Remember that. You've got those. Remember now. Piriformis, very famous for, I've got a tight piriformis and that leads to sciatic pain. 100% agree that that could be one of the things, but that could be many, many different things. And I think if you look at the complexity of the structure, I think I described it in when I've talked about the sciatic nerve. It's like, if you're the sciatic nerve, that's like going to a festival and being at the queue, and you've got a beer in your hand, and then you've got to go through hundreds and hundreds of people to get back to your spot, and you're pushing your way through the crowd and you're trying not to spill your beer. That's like the sciatic nerve trying to get through the hip and then get down into the lower parts of the leg. So when people say I've got sciatic pain and I've released my piriformis and it's still there, it's like, well, yeah, because there's a ton of other things that you need to consider and how these muscles integrate. And then if we consider the sacrum is the kind of final component of the spine, anything that's going on in the spine could possibly be impacting the place of the sacrum. So it's not quite as simple as one stretch. But so piriformis, then we've got the gemellus, inferior and superior, which is pretty simple: superior, inferior, above and below, top one, bottom one. The obturator internus. The obturators have two. We have an internus and an externus. Confusingly, well, what I think is confusingly, the internus is posterior and the externus is anterior, which I would have just assumed it would have been the other way around, but it is. And then we've got the Quadratus Femoris, one of the, to my knowledge, 4 quadratus muscles of the body, but the Quadratus Femoris is just posterior. It's the lowest one of those, which is kind of a terminal, I'd say, external rotator. So all of these help different portions of external rotation, which is what we need for different portions of hip flexion and abduction, external rotation. So if you to remember those, I've said, just remember, please give £1, and then you've got those remembered. But with the gemellus and obturators, there's 2 variations: superior and inferior, and an externus and internus. The externus is anterior, the internus is posterior. The gemellus, the superior and inferior gemellus, and the obturator internus form the coccosori, which is a group of 3 muscles, which are your external rotators, which are originating, easy for me to say, from around the obturator membrane and the ischial spine, which is actually attaching onto the posterior components of the ilium or the pelvis itself, not the sacrum, which is where the piriformis goes. So that's a key thing to know in anatomy, in my opinion, is the piriformis is originating in the sacrum, and the gemellus, the coccosori, so those 3 are in the obturator and around the ischial tuberosity. So, holy trinity of frontal plane movement and management. So I haven't spoken about the glutes. I'll show them in a second. I'll talk about the glutes themselves. The glutes, I don't want to say it's obviously we're talking about the hip. I'm not really talking too superficial. I'm talking about deep hip muscles in this particular presentation. The medial glutes, I refer to them as medium, but the minimus and medius just live in the fossa of what they're actually called, so the gluteal fossa, which is lateral to the ilium, to the outside of the ilium. They're going into the greater trochanter, which I do think, in my opinion, will be in slightly different positions, because they will. In regards to the positioning, the glute minimus is a little bit lower in terms of the gluteal line. It's a little bit, its origin is a little bit lower down, and it's going to insert a little bit more anterior and placed anteriorly, which gives it that internal rotation ability. But we're talking about the holy trinity of frontal plane movement. I think that, in my understanding, I don't know everybody's educational backgrounds, but this is the things that I wish I'd known more about when I was training people, is that we look at sagittal plane and then we look at frontal plane, which is what we're looking at here, and we don't really understand how they integrate to create sagittal plane movement or transverse plane movement. So what I'm basically saying is, when this holy trinity of frontal plane is, we have a contralateral QL, we have a medial glute, and then we have the adductor complex. And the synergistic contractions of these three muscle groups really help us stabilize the hips from a frontal plane perspective. So when we look at something very, very common to personal trainers, why do my clients' hips kick out to the side during a squat or deadlift? I'm not saying these guys are the only thing that you need to consider, but there's definitely something that you need to look at, in my opinion. And then because the repercussions of hip shift during a squat or deadlift can be quite severe, if you use a better phrase, if you're going to add load, and then eventually there's wear and tear either in the lower back or knee or further up or down. So it's very, very important in gait and pelvic stability. Understanding the anatomy and how they co-contract to create stability is very, very important. Like I say, overlooked and underrated. So things that we should really pay more attention to and understand how they stabilize, because it will help us from an exercise perspective, and also maybe intervention for rehab exercises, which as a personal trainer, as long as it's thought process and as long as it's safe, everybody's in the right to do, as long as you do have a good thought process between what you're trying to achieve. And what I mean by that is simply, right, we're going to do some adductor exercises, some glute exercises prior or after to doing a compound movement. So the adductor itself is a really, really cool muscle, which sounds pretty sad, but I'm not afraid to admit that. I just think it's quite a beastly muscle. There's loads of compartments to it. We technically have we have seven muscles with adduction capabilities, adduction and internal rotation capabilities. So to manage that internal rotation, we want the adductor to be able to contract in unison with knee extension when we're propelling ourselves in either a squat or running or any motion. So our ability to contract the quads and the adductor from an internal rotation perspective to manage the movement of the femur is key. So if we start with the Adductor Magnus, it's technically a fourth hamstring. It is pretty posterior. If you get people who deadlift a lot, it'll hypertrophy so much, which you'll probably see a thickening more in the posterior compartments of the thigh. So like a shift backwards. If you're very, very good at deadlifting, it's likely that this will have hypertrophied. What you can have as an offset is that you, as you get stronger and stronger in that sagittal plane hip extension, you then lose abduction capability. So you'll lose the ability to abduct your femur due to the fact that this is more of a sagittal plane muscle rather than a frontal plane muscle now, which I hope makes sense for everybody. If we've got a Magnus, we'll have a minimus. Just like we've got a glute maximus, we've got a minimus there, but the maximus has a minimus. You might find that in textbooks. It just depends which one you get. Sometimes it's the adductor magnus. The really techie ones, the ones that are very, very like anatomically intricate and meticulous, you'll find the minimus. In regards to the insertions, it's just down the linea aspera, but then into the adductor tubercle on the tibia. We have a longus and a brevis, which when we look at the insertion points, the origin points where they originate, they are a lot more anterior in respect to the orientation of the pelvis. So you can actually change their ability to internally rotate by how much anterior and posterior tilt you have. So when you change the position of your pelvis, you change basically change what the adductors those adductor longus and brevis can technically do, which is pretty cool. So there are internal rotators. As I said, in my opinion, the longest is more for structural integrity. Obviously, it's going to contract, but it's just to hold everything together in that massively complex pelvic matrix that's going on down there. Then pectineus, whichever one you want to say. We've got the strongest in the end range adduction. So as we bring in that, it's the kind of the muscle of crossing our legs over. So if you want to crash your mind to the basic instinct scene, think of it like that. I shouldn't have said that, but anyway. But if you cross your legs over, that's the pectineus contracting. It's kind of an end range adductor. It's going into the pectineal line or the superior pubic ramus around that, and it's got going into the linea aspera and the upper portion of the femur itself. But it's just cool to know all these muscles, and like we say, when we look at some the other guys in terms of the hip and thigh, it does have this kind of similar principles to the upper body as well. So these are the other guys. So we've got our tensor fasciae lata and our sartorius. And if you can cast your mind back to the pec minor and the coracobrachialis, they both had a common origin, which was the coracoid process of the scapula. Tensor fasciae latae and the Sartorius have the anterior superior iliac spine where they share. And that is important, especially when we look at anatomical slings and fascial integration when muscles share origins and insertions, because that basically means if one of them moves or one of them is restricted, one of them's tight, it can then impact that same joint. And then finally, we have the gracilis, which is a manager of the tibia. It also is a very, very weak adductor, adductor. Very weak adductor, so it is part of the adductor group, but it's a manager of the tibia. More in my opinion, it's internal rotator of the tibia, so it helps manage that. Because if we're speaking about what Aaron said before, when we have that massive 10 and 2 position and we have this massively externally rotated femur going into a squat, we do need muscles which are going to help manage and bring it back into internal rotation so the knee doesn't get pissed off, especially when the feet can't move because they're supporting us with ground reaction force. Sartorius is a pretty cool muscle. I never really was too bothered about it. You can train it, but you can never, it'd be very difficult to train it specifically. I'm sure there is a way, but it's a cool muscle, but very confusing way. And Aaron, correct me if I'm wrong, it's going to be an external rotator of the femur, but an internal rotator of the tibia. So get your head around that one. Right? Or
yeah, absolutely. Yeah,
cool,
correct.
sweet. So basically, that took me ages to get my head around. I was like, how the hell does it do that? But it's just because it's in origin insertion. It's going, which is from a more lateral aspect, which is the ASIS, as it says there, the anterior superior iliac spine. It then travels across. It goes cross junction, so it's going from lateral to medial and going to the pes anserinus, which is in the medial side, which means just due to its insertion point, it can internally rotate. But it's a really, really cool muscle which helps the femur integrity because it's pulling it one way whilst pulling it another, which is going to be very important during squat pattern exercises. TFL, tensor fasciae latae, is the beginning of the IT band, so that is kind of an important one. Well, it's obviously very important in that sense. From a training perspective, what I'll find with that is when people have very tight IT bands, for use of a better phrase, or they have lateral knee pain, or there's a lot of restriction in the IT band, and you can actually visually see that the IT band is almost taken over and squished, for use of a better phrase, the lateral vastus muscle. You put a dry needle in that and it'll absolutely go off like 4th of July. So it's that's an interesting one, which shows what happens is when the muscle is in a constantly contracted perspective of what it's trying to do. And in my opinion, it's trying to do something to stabilize the knee because there's a lack of stability somewhere in the hip. But again, that's for another day. Right. Go back to the Q&A. So I will stop the share there in terms of that. And let's get back to here. Oops. Okay. And who's up? Is it me talking? There we go. And then, right. So Q&A. How do I get thingy back up? Any questions about the hip? Anything you'd like to add on, Aaron?
No, I think you've covered everything now. I mean, we had a question last week from somebody asking me about books or asking us about books that we'd recommend. Mm-hmm. So I'm going to add, there's 2 books. I think if you, rather than spending 70 or 80 pounds on anatomy books,
yeah,
there's 2 books by a guy called Bernard Kingston.
Okay.
Understanding Muscles and Understanding Joints. They were the godsend for me. The attachment points are taken from Gray's, mm-hmm. So you know that they're legit. But they're just really simple books. And I think when you're trying to get your head around anatomy and the complexity of some of the terms and this concept that when we talk about origins and insertions, the origin changes based on what the one or the other end of the bone's doing. These books are really good. 20 quid, I think they are each. So they're a lot cheaper than the Moore and Daly's and the Tutor and Grabowski books that you might be using currently for your anatomy.
Sweet.
That's it for me.
Sweet. No, so we've got here.
I'll type it into the feed so people have got that book. Someone's just saying, what's the name of the book again?
Cool. Right, whilst you're doing that, I'll get on with Henrik's question. So what could be the culprit for cramping loud cracks around the groin when doing the exercise training course, sitting on the bum while cycling and the feet's rotating the medicine from side to side? What was the name? Okay. So I think you're talking about a Russian twist. That sounds like what the exercise is. Loud cramping cracks. I wish you'd told me that before. I ordered Sartorius last week for 50 quid.
Sorry, buddy. Send it back.
Is that right?
Amazon won't be delivering it.
No, I needed it. They said it was compulsory anyway. They said it was essential. So
You believe you me, once you get past your probably third year, it's too simple. The stuff that you'll start to go into when you get into your third year, it's just not complex enough. But the basic concepts, the understanding muscles, understanding joints books are fantastic.
Cool. Awesome. So we'll go into Henrik's question. So loud cramping cracks around the groin whilst doing the exercise. So I think you're referring to Russian twists. So loud cramping and cracks. So when you're rotating to your right, you have to be able to lengthen your left adductor. When you're rotating to your left, you have to be able to rotate your right adductor. Even if your hips are still, you still have to be able to do that. When you bring your feet up off the floor, you've then created a challenge to the midsection, which is essentially what the exercise is trying to do. And because you don't have the ability to either stabilize the pelvis through either intra-abdominal pressure or the abdominal musculature, or there is a tightness in one of those adductors, as you're rotating, you don't have the ability to change the length tension in that adductor, or one of many other muscles, but let's just say it is an adductor. I'm not saying which one, as we know there's several ones it could be. And because that, as you're turning to one side, that's taking the joint with you, and you're getting some sort of bone-on-bone compression, and that's what the cracking is. You're cramping because you may have, from a nervous system perspective, the brain's trying to stabilize the muscle, so it's sending a massive signal to try and go somewhere. So I would say, rather than do that exercise, look for a more static core drill, because it was, first of all, say what you're trying to achieve from that. If it's for aesthetics and you're trying to, get some abs, then, fair enough, but maybe revisit why you're doing the exercise. I'd look at the full length tension in both adductors specifically, also some thoracic. It could be your thoracic rotation, because there's a lot going on there. So if you're limited in thoracic rotation, that could be an issue as well. I probably would take the medicine ball away and work through that range, maybe stood up in a lunge position, and then see what it's like twisting from side to side, something along that lines. But yeah, I would take a good guess that the side that's cracking, you've probably got a lot of, for better use of word, tightness in the adductor, or maybe some weakness in the glute, or either or, both sides. Aaron, what would you say?
Yeah, completely agree. I don't think I've got anything to add to that, Chris. I think you nailed it.
Okay, Matan, can the hamstrings cause anterior pelvic tilt if too flexible and the quads and hip flexors are tight? Okay, are you going first, Aaron, then I'll jump in?
Potentially, yes. I mean, I think changing pelvic position because of the sheer volume of muscles, the tendinous attachments around there. I think it's a lot harder than we expect, or we kind of we think. So yes, potentially, if the hamstrings were too flexible, quads would over-dominate the hamstrings. That would pull the pelvis slightly further forwards. But I think in practice, I'm yet to see anybody who's got overly flexible hamstrings, which has caused a significant anterior pelvic tilt. I think because of the preponderance for sitting, we naturally, at some point during the course of the day, even those people are very active, we naturally shorten our hamstrings by the virtue of the fact that we're sitting for a couple of hours in an evening, or however long it is. So personally, it could do, but I think it's unlikely because of the other things we talked about.
Mm-hmm. Yep, no, I'd agree. It's unlikely. The hamstrings themselves, they've got a lot of work, and they're always in contact with the floor. If we look at, like, if that which sounds ridiculous, but if you think about it, if you think of the way I see it, and I'm just probably digging a hole now, but if your heel's in contact with the ground reaction force of the floor, they're always slightly contracted in some way just to hold us upright. So if you know, probably better off drawing diagrams, or probably I wouldn't be better off drawing diagrams, but but yeah, I think you always need a bit of structural tonicity in the hamstrings to keep us upright perspective. So I'm not saying it. I would say if somebody has a posterior pelvic tilt, it could be something going on there, but anterior pelvic tilt, the simplest thing to do is just test the length tension in them. If they go way up and they have massive amounts of hip flexion ability, then there could be something there. But I'd go down Aaron's route as well. I'd more than likely say it's a pelvic stability thing coming from the core or midsection muscles.
Yeah, absolutely.
Okay, how useful is training the muscle in action instead of function before a larger complex movement, e.g. clamshells for glute med compared to an aeroplane hinge? Okay, that's a good one. So action versus function is a really, really good one. And in terms of how useful is it, I would say it's as useful as the client in front of you. You know, what I think, no, it's not necessarily a misconception, because everybody's heart's in the right place. And this is something that I'll be looking forward to, you know, to teaching or going through people, because it's you can talk about it online to heart's consent, which I'm happy to, but until you show people what it feels like, you're trying to create a feeling or a sensation. So if you've got a client who is very, very, you know, neurologically inefficient, which is a fancy way of saying they've got poor coordination, essentially when you're training them through action, yeah, they might see an improvement, but you've got to give them the ability of knowing what state of stability feels like. So in terms of how useful it is, it's very, very useful. However, being able to understand and screen for when that is relevant is very, very important. So what I mean by that is that for some people, firing up that glute med or medial glute complex could be brilliant for them, because that's an ability that they lack. However, if they're poor at internal rotation, not external rotation, so if they're poor at internally rotating the femur, you've just sent them further into the issue that they're having. So this is why I'm saying about the glute adductor relationship is so important, because for some people, you might notice that warming up the glutes and they feel amazing, they can squat better. For other people, it won't do anything. And that's why it's a bit of a lottery. What I'm saying, the skill is when you can identify what the actual structural issue is and then what's most applicable. So is it good? Yeah, I'd definitely say so. Whether it's effective depends on the person in front of you and whether it's the right thing for them. Integrating isolation movement, so an action movement, into function as the warm-up would be the best thing. So you've said, e.g. glute med compared to an aeroplane hinge. I would say, what is the exercise you want them to do? So squat or hinge. I'd get them to do the glute med, then the aeroplane, then a light version of what you want them to do, so they're practicing the movement. And then those three becomes your warm-up. So it's action, function, practice, and keep doing that until everything feels smooth, and then off you go. Anything, Aaron?
No, agreed. I'm just conscious of the time, Chris.
Sorry. All right. Yeah. No. If you've got to go, then.
No, I'm good. I just wanted to get through a few more of the questions, if that's.
Sorry. Yeah. Cool. We'll go with Hattie's. I often get cramp in my hips and glutes when going into positions like sumo squats, lateral lunges, and find it hard to get range of movement. What could be causing the cramp, and anything that could help me get more? Could it be related to my hip and pelvis mechanics? Okay, Aaron.
Yes, I would say is the answer to that. So I think sumo, the female. I mean, I think there's a big misconception. So the female pelvis is a different shape. It isn't necessarily wider, but the angles of things like anteversion, retroversion, inclination, which are the things, if you go back onto Chris's week, was it week 1, Chris, you talked about?
Week 2, I think, might have been.
Week 2, when we were talking about the femur. So these are the angles of the head of the femur, the neck of the femur. These things are all going to start to change the biomechanics of your hip and pelvis. So it may not be that you've got a wider pelvis, you have a different shaped pelvis. And when you go into a sumo, you're biomechanically disadvantaging some of the muscles that you're talking about there. These, you say was cramping, hips and glutes, because they're trying to contract from a lengthened position or a shortened position. So if you think about cramping in the adductors, in the sumo position, the adductors are lengthened. And for a muscle to contract from a lengthened position, it's very difficult for it to do that. Conversely, on the back, your glutes, glute med, glute min, they're trying to contract from a shortened position. And if we look at muscle activation, muscle action, you know, the strongest point for a muscle to work is in the mid-range. Inner and outer range, you tend to start to lose the ability to be able to produce force. And I think what's happening is your muscle's getting fatigued more quickly because it's working from a position where it's either passively insufficient or actively insufficient. And that's what's causing the cramp, because it's effectively. Does that answer your question, Hattie? But play around with foot position, play around with your width of your squat. Maybe the sumo isn't the best position for you.
And what I would I'd completely agree. And what I'd add, if you dig out podcasts, listen to the podcast I did with a lady called Katie St. Clair. We talk a lot about sumo deadlifts for women in that one. Just give that one a listen. There'll be some good insight into that.
Things like so I've got when I had pain in certain areas, I was doing a lot of clowns and things like that, and I find those quite difficult as well to kind of get into that position. Would they be the best things for me to do?
I think you've got to look at what is it that's stopping the range of movement. So is it the hip joints? So do you need to do some work around the hip joint, you know, open up the hip joint, get the joint capsule loosened off? Or is it some kind of muscular tightness? So I think you'd have to investigate a little bit deeper to work out why on a clamshell you've still got that reduced range of movement.
Yeah, it does feel like it's getting kind of stuck.
Yeah. Any history of hip dysplasia? Any sort of congenital stuff in the family?
Not that I'm aware of, no.
You didn't have frog splints when you were a kid? Your legs weren't splinted?
No, I was just really, my feet were turned in. That was the only thing.
Okay. So what do they call that? What's the...
I'm now very flat-footed.
Right.
So
I think it's probably, you know, these things are never just one joint. It's usually a combination of things. So the flat-footedness drops your knees into a valgus position. That changes the position of your hips. Joint mobility is a combination of a variety of different things. It's the joint capsule and the gubbins of the joint. It's the muscles. And then it's the kind of sliding surfaces, the skin and fascia that go over the top. So I think exploring what it is that's tight and that's reducing that range of movement, working through that, if that doesn't resolve things, then maybe you can get these osteophyte growths, little bony growths, and sometimes they develop. If it's bilateral, it's unlikely, but if it's unilateral one side, it might be that you've got a little bit of a bony growth that's actually impeding the abduction or external rotation movement of your hip. But I'd go down the route of loosening stuff off, trying to work out what it is, where the restriction's coming from, and then chase that for a bit before you start to think about, you know, bony restrictions and things like that.
So going to Henrik's, who's saying also struggle to sit upright with legs out to the side or lifting the femur up in circular motion, same kind of pain. If that gives any more information. And they're saying, could pain while doing clamshells because of tight adductors as well? So I'm guessing that, Henrik, that you're going to have quite a high amount of anterior pelvic tilt, which basically is the hips falling forward. Is that the case? Yeah. So you've got quite a lot, because all the things that you're describing is just biomechanical restrictions. You're talking about what's going on, all these symptoms, which is pointing to one like central movement issue, which I'm not saying is going to be the be all and end all, but if you could do something where we're looking at a bit more posterior tilt of the hips, so you do just something where, think of like a dead bug, but you go into that position and just explore how that feels. that's going to be hard for you. So if you were to lie down on your back, put a pillow or a foam pad or anything underneath your hips to promote a more posterior tilt position, just hold that position and then just do some hip circles very, very lightly. You're probably going to feel your lower abs. You'll either feel one or two things. You'll either feel your lower back straight away, which means you're incredibly weak in that position, or you'll do a few and your lower abs will be burning. If they get that burning sensation, that means they're fatigued and there's a mismanagement of the pelvis. If you can do that with some core stability drills, but my go-to for you would be more supine core drills, so on your back, not your front, because just by gravity and positions will be more promoted to have a posterior tilt rather than anterior tilt. So for example, if you were to do something like a bird dog, that would be a good core exercise, but a mismanagement of the joints, because as you get fatigued or from the off go, you're more likely to go into anteversion straight away, because as soon as that hip comes up, you're just going to go into your natural position of lordosis or more bias to that. So try some dead buggy lying on your back type of movements and see how they are. If your lower back hurts, please stop doing it. But it's because you're weak, with all due respect. It's just it's a weakness. And don't be offended by that, because I know plenty of powerlifters, you put them in that position and they're absolutely crying after 10 seconds, which I'm sure Aaron knows of as well.
Yeah, it's my favourite thing to do.
Yeah. Right, cool. We'll take one more, which is Luke's. Quick one for improving hamstring range of motion, active or passive mobility stretching. Aaron, well, sorry, first thing I'd say is, why do you want to improve the hamstring range of motion? If it's not unilateral, so if there's not a bilateral discrepancy, think about who's it for first. So that's not saying you should never do that, but what I would say is that there's not a great deal wrong with having tight hamstrings, as long as it's not ridiculously tight and it's not bespoke to one side, so it's not just unilateral dominant. But you definitely would want to improve them. But Aaron, I'll let you go.
Yeah, similar. So if it's bilateral, I think the thing is you have to consider that when you're stretching a muscle, you need to work upstream and downstream of that muscle. So work the joint above, work the joint below. So stretching on its own is a short-lived effect. You'll find that stretching lasts for a few minutes. It's a neurological reset. It calms the nervous system down. So mobilizing the hip joint, if we're talking about the hamstrings, mobilizing the knee joint, if we're talking about the hamstrings, so the upstream and downstream joints, and then camping out in a passive stretch for 2 minutes upwards seems to have the best effect in terms of changing the length of the fascicles in the muscle. Anything less than that, you're not giving the muscle time to elongate. So I think it's a case of working the joint, mobilizing the joints above and below, and then sitting in a long sustained stretch where it's not about 30 seconds. You're looking at 2 minutes, 3 minutes upwards. That induces something called hysteresis and creep, which is where you're starting to elongate the tissues in the muscle, and you have to do this chronically. This has to be done every day.
Sweet. Let's see. Perfect. Cool. Yeah, there's not a lot to apart from just putting everything into context, which I would add to that. Stretching. The thing which I'm not massive on stretching is because it's exactly that, is that the time investment needs to be quite, not just the actual time itself when you do it, but the consistency and that. So you've got more chance of people sticking to a low calorie diet than actually getting them to stretch. It's one of those things where people are just as adherent to the diet as they are to the stretching protocol. So it's not that it's a bad thing. It's very, very good. Yeah. So it's very, very good thing to do. It just depends. But really, in terms of the hamstrings themselves, they are very, very good to stretch, and I would recommend that protocol. However, it's usually a symptom of something else, which is the lack of stability above and below. So feet and hips and feet and midsection, trunk, and then from there. Cool. Right. We'll wrap it up there, just because I've been on for nearly an hour and a half. I'm going to, Aaron, if you can stay on.
Yeah, of course.
So we can have just a quick chat afterwards. But thanks very much for coming, guys. You can feel free to leave the meeting in your own time. I'll ping this up onto YouTube later on today.